Everybody, hope we're all doing good. Got something a little bit different today. We've got Amit Patel, the Essex dentist, coming on, and he's going to talk us through his immediate process behind doing that, behind offering it. I'm quite interested to hear this. It's not something that I've particularly done, so I think that'll be quite good to sort of pick his brains on it. If you don't follow the Essex dentist, make sure you get on that because he does some really good stuff. Hopefully we can get him on quite quick. I know he was a little worried about getting stuff on, so let's just ping him through and see if we can get him in. Let's see. Hope everyone's doing good. Who have we got on? Looking good. But I hope everyone's doing good. Not having too many thunderstorms. It's a bit patchy in the UK at the moment. Here he is, the main man. German tequila. How you doing, buddy? You okay? Dun, dun, dun. Let's get him in. And we got people from Belgium as well. How you doing, buddy? Oh, he's unable to join. Oh dear. The pressure's on. It's looking good. So usual stuff, people. If we got, hey, oh, you had me sweating there, man.
Am I on?
You're on. We're live. We're
going. Am I on the right live?
You're on the right live. I know. I've just gone on and saw someone else's live. I was like, oh no, we're going to lose people. How you doing, man? You okay?
Yeah, all good, thanks. Yeah, just busy day at work, and now looking forward to doing this.
You're purely in the city right now?
No, I'm working across two practices. So
it's your family one as well, right?
Yeah, so one's in Essex, that's the family one, and the other one is in central London near Liverpool Street. Mm-hmm. So, yeah, no, I get a good mix. I think, central London is a bit of a different, beast. Mm-hmm. There's a lot of dental practices around, lots of clinicians, really good clinicians as well. And yeah, we're just sort of starting out there and just trying to make a few changes to the practice. So, it's going well so far. Essex, it's a bit different because it's like a village, and you get people that come every 6 months. They bring their family. So, whereas London's a lot of city people, and they're in business. So yeah, it's nice having actually the two different demographics of patients.
My demographics more your Essex practice. I've got the little village, the families, the 6 monthers. How's the city vibe been over this period? I know initially a lot of friends who work in the city were saying it's been a bit tricky with obviously less people working.
Yeah, I think last year when we went back to work in June after the first lockdown, it was it's a bit worrying. You walk into work and it's like a ghost town. Mm-hmm. And when you start seeing businesses like Pret a Manger and Costa close down their sites in Liverpool Street, that's a panic. But they're all back up and running, and the practice is super, super busy, which is good. I think, probably like a lot of dentists have found, we've all been just so busy. People want to get stuff done.
Absolutely, so,
yeah, just absolutely ran, which is good.
So obviously you covered a little bit there about where you work and stuff, but for people that maybe don't know, you just give us a little intro, your background. I know you've done a lot of extra training. I polished up by listening to your dental leaders ep again the other day, so that was a really good one, man. But yeah, just give everyone a little intro about yourself and your background and why you want to talk about immediate bridges today.
Yeah, hi everyone. So my name's Amit Patel, one of probably about 25 dentists that are also called Amit Patel.
You got the right one on, yeah?
You got the right one. But no, yeah, basically I qualified for University of Leeds 2013. And I quickly just went into postgrad training. I'm not a specialist. I'm a GDP, and that's the kind of work that I love doing. And yeah, I started out early doing courses and postgrad, doing it with good institutions like the Royal College of Surgeons and King's College. And I just felt that gave me a good structural program to learn the kind of dentistry that I want to provide my patients, and also dentistry that I enjoy. So the reason for picking this topic, it's mainly, I just want to hopefully discuss and give a few nuggets to some people, golden gems, of little bits and pieces you can take back to practice tomorrow. Doesn't have to necessarily be on, providing immediate bridges. It's quite a niche topic, but there's just little bits and pieces from extractions to a little bit on occlusion, maybe patient communication that people can take away and learn. So yeah, that's the reason why I want to do this topic.
Perfect. So I mean, and you did the distance MClin at Guy's, right? That was your
Yes, yeah. So that was 4 years distance learning part-time. The good thing about that program is I could work in practice and then obviously go and do the contact days when I wanted to, or when it was, I think it was like once a year.
Mm-hmm.
So I could take back what I learned from the contact days and then go and do it on my patients. So that was quite good. I was a little bit skeptical about doing a full-time MClin dent because then, and this is maybe a generalization, but I just didn't want to lose that skill of being in general practice. Because I like the pace of general practice, I like interacting with people. I didn't really want to be in a full-time position in hospital, but that's just how I wanted to do it in my practice.
That's just a purely selfish question because I'm weighing up the two at the moment.
Oh, really? Yeah. I think, mate, they've both got their merits, and it's just like a lot of things, go with your gut. What your gut's telling you, yes, you can get advice from other people, but just do what you feel is right for you in your situation. I just knew that I always wanted to be in practice, and when you're in general practice, you've got to be realistic the way you treat the patient. Mm-hmm. You've got to look at doing things the right way, as close to textbook dentistry as you can get it, but that's sometimes not always the case. We don't have the luxury of just doing perio, waiting 6 months or 3 months for the reassessment, plaque-free scores, and then moving on to other bits and pieces and pros. I'm not saying, we're cutting corners by not doing that. It's just in general practice, you can learn a way of managing both at the same time, as long as the patient's on board and you're reassessing the patient's motivation. Whereas hospital is very much, you do this, wait, then next bit, and before you know it, the treatment plan's taking 2 years to finish.
Yeah. No, it's definitely got its different sort of ways of, I'll work it out. So, I mean, let's jump in, man. So these immediate bridges, what sort of cases are you looking at? What suitable thing? Are we talking anteriors? Are we talking posterior? What sort of cases are you using it for?
I think mainly it's anterior, it's the aesthetic zone. Mm-hmm. That's where obviously patients will want tooth replacement, anything in the smile. And the reason why we're talking about immediate bridges is because, a denture is an alternative, an immediate implant and you immediately load it is an alternative, but you've got to be able to give the patient the 3 options and let them decide. And I feel sometimes maybe GDPs, because I don't maybe understand a lot about immediate bridge work and the occlusion and how you manage that associated with it, their go-to would be to give like a spoon denture or a single tooth or multiple tooth partial denture. Mm-hmm. And actually, if you just step back from the case and look at it, you might be able to provide the patient with a really decent provisional bridge or an immediate Rochette bridge, and it'll be more comfortable for the patient. They'll have more confidence. If they haven't worn a denture before, there's less, adaptation to this type of appliance. Mm-hmm. So, if a patient comes into our practice and you've got an emergency slot for half an hour, they walk in with a fractured upper central, maybe a root fracture on a upper right one post crown. Mm-hmm. You've got 30 minutes to sort of decide how you're going to, temporize this patient, and get them walking out with a front tooth. So, there's lots of different things that you could do. And I'm not going to go into all of them, but if we're starting with that scenario, then I would focus on just getting something there for the patient, whether that be a whole tooth quickly built up out of composite, re-cementing the post crown if possible, even if it means just attaching it to a teeth either side with a little bit of flowable and the patient's aware of that. You just need something to stabilize, that situation, and then you can start to plan for your immediate bridge work. And, that would start with an aesthetic assessment. And you'll be looking at the patient's lip line. And particularly with work like this, you need to account for the soft tissues and the gingival biotype. because when you're removing that tooth, when you come to remove that tooth and place your immediate bridge, you've got to try and anticipate some form of bony remodeling and soft tissue changes and recession, especially if the patient is a periodontal patient where they've had extensive bone loss. So these are all the things that you should be looking at when you're potentially going to provide your patient with a fixed restoration as an immediate option. So I would start off with that sort of case assessment, with measuring the pocket depths, taking note of the gingival biotype and the lip line, and obviously assessing the occlusion and seeing if there's actually space on the teeth either side for you to cement a wing, or whether the teeth either side can be prepared for some sort of crown. So there's two ways that you could do it. The metal rochette way, like your sticky bridge that you can stick to the teeth either side, or just a one tooth, or you go full coverage and you make a PMMA acrylic bridge, like shell temps that you reline on the day of fit. So that's essentially what I'll be looking at as a brief note as to when the patient comes in with that fractured tooth. And then I guess the next thing is, once you've got your, I mean, some people might be taking digital scans, like an intraoral scanner. So once you've got a scan of upper and lower arches, or if you're doing analog conventional impressions, you need your upper and lower impressions and your bite reg. Once you physically got that, it always helps to send photographs to the lab. You've got to have a really, really good relationship with your lab tech, so they understand what you want. There's no point in just writing, I want an immediate bridge for upper right 1. You've got to prescribe quite a few technical points for this type of restoration, for it to be a good outcome, both aesthetically and functionally. So again, with the lab prescription, the first thing that you'd obviously want to do is the shade. That needs to be right. So again, lots of photographs, and shade tabs. Put the shade tab where the gap is, and just take photos for the lab technicians so they understand the shade selection. And you've got to prescribe what type of, if you're going to provide a Rochette style bridge, you've got to prescribe the type of wing that you want and the Pontic design. Now, for best aesthetics, an ovate style Pontic is going to be the best. And the reason why I say that is because that's physically going to go into the socket and support the soft tissues to prevent collapse.
Yeah, that was literally going to be my question, is are you sort of pre-planning? Does it vary with what you're thinking for your definitive as well? What kind of sort of gingival maturation you're going to be looking at achieving?
I'll try and show you a picture of what we're doing with like the Pontic and how much soft tissue support you actually need, because I think some people will be quite surprised at how much we're going into the soft tissues. So can you see my screen here?
Perfect, yeah.
So if you look at this image here, so we're actually supporting the soft tissues with an ovate Pontic with about 3-4 millimeters. And that's what I prescribe to the technician for most cases. And what that's doing is, not only does it help achieve hemostasis on the day of extraction because you're putting pressure on the blood clot, but that's going to support your soft tissues and prevent collapse of that. Because we all know that as we're getting into aesthetic dentistry and we're looking at these, high-end cases, we're looking at the pink and white aesthetics. And we want that. We want, obviously, to maintain as much soft tissue as possible, whether it be for your final bridge work, whether it be for your final denture, or whether it be for a final implant. It does not matter what type of restoration the patient's going to end up with, the definitive one, but as your temporary measure, when you're providing an immediate bridge, you want to support these soft tissues. So that's the kind of extension into the socket that I'm going for most of the cases. And if it's too much, then we'll just trim it back. What will also depend on that is your probing pocket depths. and that's something that you should actually prescribe to your lab technician, or even send them the PA or the X-ray so they can see the bone levels, and that will give the technician a guide as to how much soft tissue collapse we can expect or bony remodeling. Because you're going to see this patient for a 3-week review, then you're going to see him for probably a 3-month review, and you're going to want to see how the soft tissue has changed around your pontic. And the likelihood is, in a perio case with bone loss, that's going to have shrunk back actually quite a lot. And you want the pontic to support the soft tissue as much as possible. Does that make sense?
Same with your immediate dentures and things like that. It's always handy to know what to expect in terms of recession, and particularly if you're doing, as you say, most of these cases are aesthetic zone stuff, because that would be my sort of concern with these sort of immediate bridges. You say, but if that initial 1 month of that's the quickest rate of gingival change, that suddenly you're going to have a big gap underneath, and then obviously that's aesthetics and then cleanliness and
exactly. So you're better off having it more 3-4 millimeters from the beginning into the socket to account for that soft tissue change. And yes, I'll show you a case later on. When you do get a big soft tissue change, they don't look great, but obviously it's going to be better than a dark space between the cervical region of the pontic and the crest of the ridge. Patients will get all sorts of issues like a lisp, food trapping. So always support the soft tissues where you can. It's so important when you're providing work like this. And going back to the Richette bridge prescription, so I've talked a bit about the pontic, but with regards to the actual lab prescription, so these are the kind of perforated holes that we want in the wing, because I want to be able to easily remove this at a later date. What you don't want is no perforations, because they're so much harder to remove. And if this comes back to you, just get a diamond burr and drill the holes yourself. So, if it comes back to the lab, even though you ask for holes, perforations, sometimes it happens, the lab don't read the docket. You can just easily create these perforations yourself with a diamond burr and then just polish it. But that allows the mechanical lock, so you can, with the cement, and you can easily drill out and remove that mechanical lock to remove the bridge at a later date. Now, what you'll see here on my screen, can you see this sort of green box? Yep. So what we're looking at actually is this area here where the wing almost meets the incisal edge on the palatal aspect. And what you should ask your lab tech to do is actually to create a little space there. So they will add in an area of wax. So you can, at a later date, you can slide in your carver or your flat plastic, insert it into that groove that they've made for you, and you twist, and these things just pop off really easily. So it's quite a neat design feature, just to ask for a little bit of space that the cement will fill up, but then you can easily remove that cement at a later date to twist these bridges off. And that's actually how I remove permanent bridges. So if you've got a existing Maryland bridge and the patient turns up to your practice, they want it replaced or you need to remove it, I actually get a very, very fine diamond, and I actually create a space between the wing and the tooth to enable me to insert a fine instrument like a thin flat plastic, and then just a simple twist, these things just twist off. It's quite easy. You will see here as well that I've asked for a location lug or tag. So this is an extension of the metal wing that seats over the incisal edge, and that just helps and aids in seating when you come to fit this on the fit appointment. We don't obviously use any cement there because we'll be cutting that off. So we cut that off and then we polish it back. But that again is something that you need to prescribe with your lab. You'll be surprised the amount of lab techs won't do that without you requesting it. So make sure that you're requesting this stuff when you're talking with your technicians.
And in terms of the Richettes, or sort of the more conventional ones, do you have any specific things? Bar the obvious, this tooth doesn't need prepping, so I'm going to do Richette. Are there any certain situations to avoid, certain occlusions or anything like that?
Okay, I mean, as a generalization, obviously the one you've got to look out for is class 2. Patients with a really deep bite, there's hardly any space, and there's a risk of them shearing off because they have a restricted envelope of function. Those lower incisors are going to come clashing up against your metal wing. So if you have to go, it's not ideal, because if you speak to a restorative dentist, it's no different to doing a dial case with composite or veneers in a class 2 patient. It's never ideal, and that has to be planned properly if you're not going to do ortho before. But with a case like that, if you can squeeze it in and you can do a no prep rochette, then I would go double wing.
Okay.
And that will just increase the longevity, but it also gives the patient a bigger bite platform, a bite stop they can positively bite onto. And you would ask your actual lab technician to include on the wing here, on the platal aspect, an actual bite stop or bite platform that the lower incisors can rest into in ICP. The worry is if you've not designed it properly, the patient will actually continue to slope further back and they'll end up more class 2 as the mandible retrudes backwards. Does that make sense?
Yeah, put them in a Michigan almost, driving them back.
Yeah, exactly. And again, with the no prep, sometimes I'll put glass armor bite stops on the first molars just to take some of the pressure off the anterior wing. And I warn the patient that, we're just allowing for a little bit of occlusal settling. And in order to aid that and to increase the longevity of this provisional bridge, I'm just going to put a little bit of semi-permanent material, which is GIC, on the molars, and that will just help keep the occlusion stable while they're essentially stabilizing with the no prep wing. So that's how I'd sort of manage those cases with the occlusion.
And are you asking for anything in particular on the pontic itself, out of occlusion, light occlusion? What are you asking?
Yeah, so that just goes back to normal bridge design principles, and that would be you want most of your ICP contacts on your wing. So you want positive bite stop on the wing, and you want a very light ICP contact on the pontic, almost shim stock only. And in lateral excursions or in protrusive movements, you want that clear from the pontic, because when these bridges debond, they'll normally debond if they've got excessive forces in lateral excursions or protrusive movements, because again they want to peel off, and that's the principle behind how we remove them. Again, if I want to remove this bridge in front of you on the screen, sometimes I would literally just put a plate of the buccal pressure with my thumb and it just pops off. And you can imagine if you've got someone who's grinding their teeth, if they are catching that, it's no different to you pressing with your thumb in a place of the buccal direction. They'll do the same with their lower incisors hitting that incisal edge. So you need to make sure that's free of excursions and protrusive movement.
Perfect. So you've then got that all prescribed. The conventional ones, is PMMA, or what are you making those?
So with the rochette one, we'll talk about conventional in a minute. So with the rochette, I'll ask for the pontic to be in composite. And the main reason, obviously, it can be easily added to and adjusted and easily polished. So again, going back to the ovate pontic, soft tissues respond really well to highly polished composite. We use it in implant dentistry all the time. If you look at dentists that do a lot of deep margin elevations with their posterior composite, the soft tissue actually responds really well to dental composite. And it's no different with anterior bridge work on your pontic. And so again, going back to the original question, with using composite, that can be adjusted or added to. If you want more support in other areas, you can add composite and polish it up with discs. Again, if it's too much support or it's putting too much pressure in the wrong area, you can adjust that and polish it. And again, it's an aesthetic material. It comes in a range of shades. So I always ask for the pontic to be made out of composite for that reason. With a conventional style temporary bridge, so I'll bring up a picture of one of those. So this is like a PMMA bridge. Mm-hmm. The orange material that you see is just silicone bite reg, and I've actually used that as a jig to aid seating of this bridge in the patient's mouth, so I know it goes back and forth into the same area. Mm-hmm. And with this type of bridge work, this is made out of PMMA, highly aesthetic, and also very strong, a lot stronger. It's less brittle compared to chairside temporary materials like Pro Temp, Quick Temp, or Luxor Temp. Mm-hmm. So if you've got a case where you want to, manage aesthetics, a function, speech, occlusion, you want the patient to be in temporary bridge work for 3 to 6 months, I would always recommend getting a lab-made provisional. Mm-hmm. It is just stronger, it will last longer, and they do it really
better.
good. Yeah, they look better. And again, you can reline these, you can bond composite to them, and you can polish that up. So again, it's a great material. And again, on this slide, you might be able to see this middle picture. So again, in the case like this, where I'm doing an immediate temporary bridge in the form of conventional crown and bridge work, the technician has actually prepped the adjacent teeth on the model. Mm-hmm. And they've removed the teeth that I'll be removing in the patient's mouth. And you can see how they've actually used a burr to burr in the stone, the actual soft tissue, the actual socket, mm-hmm. and the soft tissue profile. So you need to ask your technician to actually create this dye preparation in order for them to make an aesthetic bridge that's going to support the soft tissue. Mm-hmm. So these are all the little steps that you've got to ask your technician to do, because otherwise they won't do it and you won't get the bridge work that you want back. And then obviously the patient might be unhappy.
Got to find the right tech for something like this, definitely.
Yeah, but again, everyone also does say, you got to use this technician, use that technician. They're the best. I've seen their work, or they're great on Instagram. But actually, there's a lot to be said of just using your local lab down the road and just working with them. Mm-hmm. Just spending time going through cases like this, because they've actually probably not had a lot of dentists come to them and want to work with them with this level of detail. And they find it quite exciting that, this dentist actually wants to do really nice work. I'm going to spend a bit longer on this because I want them to be happy, and this is the kind of work that I enjoy. Yeah. So again, it's just opening that conversation with your technician to ask them, are you willing to work like this? And is this something that we can learn together? Because you will learn a lot from your technician. They're a very important part of the dental team. So just make sure you're spending time with them going through these cases, because that is what makes a good dentist a great dentist. We rely heavily on our technicians, and you know that.
Oh, absolutely. No, that's always, like I said, with my, I think like when I did Jazz's podcast, what we talked about is, even if you use your local, say, lab or that corporate lab, there's always going to be someone there that's keen and wanting to do more, and it's just finding those right people to do these kind of things with. So you've got your models all turned up with your temp on it. Day of fit, surgery day. What are we looking at? I know you've got some surgical tips that you want to go into.
Yeah, so surgery day, so obviously consent the patient, numb them up, and it all starts with the extraction. If you damage that soft tissue during the extraction process, the game's over. Mm-hmm. And I know this sounds silly, but it is so important that the extraction should actually be the longest part of the procedure. Fitting the bridge is easy. It's actually the extraction process that you've got to take time with, for many, many reasons, not only just maintaining soft tissue and avoiding damaging the bone, but also patient comfort and their experience. One of the biggest practice builders is, can you give pain-free injections, and can you take out my tooth without harming me or putting me in pain? Mm-hmm. You'd be surprised the amount of patients that I've seen in emergency for 30 minutes. I've taken out their lower 7, and then suddenly they're coming back. They want a full mouth of veneers, or they want full mouth rehab, or they want a denture. You know, there's something that, you know, if you can do a great job with the extraction, automatically you've got their trust. They're on your side. So yeah, yes, it does help with the clinical execution of the case, but actually as a practice builder and building trust with the patient, it's just, it pays dividends to spend time on the extraction appointment. Just don't rush it. So the way that I do it is I will always go around with a 15C blade first. So I'll be using something like this here. That's a 15C blade. And the reason why I'm using that is I want to sever the PDL fibers that are connected to the root and the cementum. Because if you rush, again, the main reason why we're taking these teeth out is there's been some form of trauma. You know, there's decay, there might be granulation tissue, there might be infection, and basically the soft tissue ends up becoming granulated, and it basically sticks to the tooth. So what you don't want to do is rip that tooth out and take the soft tissue with it. So what I do is I'll go around with a 15C blade first, cut all the PDL fibers very, very carefully, and then I know the soft tissue has been removed or lifted off the actual tooth. So that's number one, to avoid soft tissue damage. And then I'll go around with a peritome or a very, very fine luxator. And we'll spend our time with a fanning motion, trying to go all the way to the apex, avoiding damaging bone, and always supporting the buccal plate with your thumb. And then once we've severed those PDL fibers, we can then think about putting root forceps on the tooth and carefully taking out a central incisor with mesial and distal rotations. Never ever put pressure on the buccal plate, because if you lose the bone, you will lose the soft tissue. And that is one of the things that's going to make your bridge not look so good in your 3-week or 3-month review. So start off with that. And then the next thing is always clean the socket out. You have to clean the socket out. If you saw the amount of crap that came out of a socket when you clean it, you'd want to do this every single time. And obviously, weirdly for us, it's quite satisfying cleaning all the you know, all these cysts and granulation tissue out. But the main reason why we do this, not only does it considerably help with healing and healing time, but also your dry socket incidence will significantly reduce, almost disappear. I was saying to Rupert before we joined on this call that I can't remember the last time I had a dry socket, because I'm following this protocol. And I believe that starting off by using very, very fine instruments and then spoon excavators that go right down into the apex of the socket, if you clean out everything and you get fresh bleeding in there, your patients will not come back in pain asking for antibiotics or with symptoms of a dry socket. So again, it just pays dividends to spend more time now rather than wait for the patient to come back in pain, and then you've got to deal with the issues of a dry socket. Yeah.
Which comes back again with what you're saying about practice builder and whatever. If you can do it and there's no issues, and then that's always going to help. Yeah. But I think the only time I've done something sort of similar to this, I did it for Nick, for my boss. It was at Upper Central, and that was amazing. He's like, you're going to clean all the crap out of that for 15 minutes.
Yeah.
Because and what I ended up, it was sort of took the root, more edge of the root off, composite, domed it all out, made it ovate, and just bit of flowable either side. And then he's gone in for looking for implant stuff. So obviously, if you get it cleaner, you're going to get better quality bone faster, and
Yeah.
So that was pressure, because I knew he was going to be taking a CT scan of it in 2 months' time or something. And she was in the other day, and it looked really good.
And I mean, this literally takes 5 minutes to clean it all out, and it is just doing better dentistry. Yeah. That's what we want for our patients, and it's providing that care that they deserve. So you can buy these instruments. These are really good. They've got quite a long shank here, and that goes right down into the socket. It's not so easy if you're just trying to use your standard excavator that comes on a restorative kit. You've got to get something with a long shank that's going to be able to go right into socket and clean it all out.
We just had a question from Jean-Marco, just asking, where can we read more about these sort of XLA techniques? Any papers that you know of, or any certain surgeons that are out there?
I can't actually think of any off the top of my head, to be honest.
Slide in your DMs later, yeah?
Yeah, I just think with, I mean, there obviously there are tons of papers on, a traumatic extraction technique and how that will benefit the patient and your soft and hard tissue. Yeah, there are tons of papers on that, but the actual technique, again, this is something that I've just learned. There are probably people that do it slightly differently, but I would just start, if you're not doing this already, I would just start with this process. Just lift off the soft tissue with a blade, find luxators, carefully remove the tooth. It's just spending time. That's all you have to do. We all know that if you spend more time on something, you're going to get a better outcome, whether it be a composite, a denture, an implant. If you've got long enough booked in your diary, you know that you're going to do a better job. And it's the same with an extraction. It is not just taking a tooth out. There are so many processes along that way that we can be better at, and it will help the patient with the healing process. So yeah, clean it all out. And then also on this slide, there's these degranulation burrs that you can buy. Again, that's something that is slightly more expensive to clean out the socket. It removes all the granulation tissue. But I really just like these sharp spoons that you can just really, really clean everything out. And again, you'll be surprised, if you're not doing this already, you'll be surprised what you will be getting out, because it's shocking sometimes how much crap there is at the bottom of these sockets that are infected.
Yeah, absolutely.
So with that extraction, once a tooth has been delivered and removed, I will always place a collagen sponge into the socket. I find that helps, one, with hemostasis, but again, it's another way to support that soft tissue. Because you've physically got something in the socket, you're going to prevent that soft tissue collapsing into the socket. And then one simple horizontal mattress suture, and I normally do that with Vicryl Rapide. It dissolves within sort of 2 to 3 weeks. And again, the patient's normally happy with that. So that's how I would manage the extraction process. It's just following those steps, and the patients never really come back with a problem if you do that.
Perfect.
So yeah, I think that's sort of a bit about the extraction process. What else is there to go through? The fit.
Yeah, fit, and then you've mentioned reviews as well, various time frames and things like that. So the fit, what are you first off, what are you cementing with?
So because these are obviously temporaries or provisionals, I rarely will use something like Panavia because that sets rock hard and you just won't be able to get it off. I would only use Panavia if the patient's literally flying to Australia for 6 months, and I just don't want to risk this thing coming off. But if they're in the UK and you're planning to re-enter in a few months' time to do a definitive bridge or implant, then I will just use glass ionomer cement. And you remember, because you're Rochette, that's you're going to get a chemical bond with the metal wing and the tooth surface, because the GIC will bond to the calcium ions in the tooth. But you will also get a mechanical lock from those holes, because the cement will flow through those holes and create a lock. You tidy it up and just polish it, and they'll stay on pretty well. Now with same
for the conventionals as well?
Not glass ionomer. So for the conventionals with acrylic, they'll normally go on with temp bond. Or again, if they're long term, I will go with zinc phosphate or poly-F. Something that's going to stick a bit better, but is also retrievable. One of the best tools in the practice is a crown and bridge remover. Have you used one of those?
I haven't. Which way are you talking? The sort of
the hammer end,
the pincer bit, or the the weight.
The weight, yeah.
It looks like a medieval torture device, man.
Do you not use it?
I've just seen them about and I think, I'm not sure what the patient thinks if you bring this.
Do you know what? I couldn't work without that. Because I do so much crown and bridge work, I'm taking on temporaries on and off all the time. And yeah, the weighted instrument for removal of temporal bridge is easy. It's just didn't and it's off.
Yeah.
So, but that's a great tool. And again, if you cement something with temp bond, it will come off. If you've got multiple abutments, I will mix the temp bond with a bit of Vaseline.
Okay.
It softens the cement. So let's say I'm doing a temporary bridge and it's 6 units and I've got 4 abutments, then I'll probably mix the temp or ask my nurse to mix the temp bond with some Vaseline. It softens it again for easier removal. And again, that's no different if you've got a fantastic anterior crown prep on a natural tooth with perfect taper. Those are hard to remove, even with temp bond, when you come to take it off. So just mix the temp bond with a little bit of Vaseline. Or ask the patient to, the morning of the appointment, about an hour before, ask the patient to have very, very warm water and to hold it around their temporary bridge or temporary crown an hour before they come into the appointment, because the heat softens the cement and it just comes off so easy. So
that's a good tip.
Yeah. So it's a useful tip. And yeah, so with the, I guess another tip as well, if you've got multiple abutments again for your bridge work and you're trying to develop the soft tissues and you want the patient to improve their cleaning, you demonstrated TP brushes, but the soft tissues are quite inflamed just from poor gingival health. What you can do is cheat slightly, and you can get from the chemist like a steroid ointment. The one I use is terracotril, and it's basically a steroid cream, low dose. And again, you can mix that with your temp bond.
So your margins are sort of...
Yeah, and then that means that your margins now have steroid, which is antibacterial, around your temporary crown and your soft tissue. And you will find that when you remove that, you will get no bleeding around your temporaries. So I think use a caution, because you've got to read about the steroid. But that can actually, if you've just got that case where you're really struggling to... the case that comes to mind is I had a patient where I was doing bridge work in the anterior zone, and she had lichen planus, and her gums were just so inflamed. Her OH was immaculate, but she had lichen planus, and no matter what we did, I just couldn't get the soft tissue looking right around my temporaries. It always just looked red and inflamed, and because she had a high smile line, it just looked naff. Because every time she smiled, she had this red and inflamed gingiva around my temporaries. So what I did is I mixed steroid ointment with the temp bond, and I left her in there for about a month. And I was shocked how the lichen planus had just healed. So yeah, it's just little tips and tricks like that in these weird situations that it can really help you and again, help manage the case that is actually quite tricky.
And in terms of day of fit as well, obviously you're going to be checking aesthetics, but that's sort of all part of occlusion. What are you doing certain tests at that point?
So
you said about your stops and things like that.
Yeah, so hopefully you've all pre-planned that with the lab, so you know exactly what you're getting. But we all know that sometimes not realistic when you fit it in the mouth. But hopefully you've done everything possible to get that bridge in the right place. So you would have a jig made out of Duralay or silicone, like you saw my one with the orange bite registration. That allows accurate seating, so you know it's in the right place. So the lab would have managed the occlusion on their side. You've got the location tag on the rochette, again, so you know it's in hopefully the right place. So if you've got to that point, you know that if there's an issue with the occlusion, it's actually not because you've not seated it in the right place. Yeah. And then what you've got to be looking at is ICP contact should be on that wing. And your patient, if there's no prep and you don't actually have any space, then the patient is going to have some sort of posterior disclusion or separation. So always pre-warn the patient of that. And that's where I will put bite stops on the molars in glass ionomer to help hold that. Now, we should only really be getting about 0.5 millimeters of posterior separation. That is it. Yep. If you're getting more than that, then you need to go back to a drawing board. You're not doing something correct.
That's that whole like 3-to-1 ratio, anterior to posterior, that kind of thing.
So right? Obviously, if you raise the OVD anteriorly, you're going to get less at the back. Yeah. But it's also in the fact that patient tolerance, they're not going to tolerate more than that on one tooth. And also there's risk of debond. And the fact, essentially what you're fitting is a single tooth dial appliance. And, you know, that can be unpredictable. You could get, again, if you're not really assessing these points, you could get splaying of the tooth with the wing on. Or obviously you could just get a debond and the patient will be unhappy. So it's just making sure that your plan is properly. You've got the ICP stop on the wing, and going back to the points about light contact with shim stock on the pontic and no contact in lateral excursions, because these bridges will tend to peel off in a palatal to buccal direction.
Perfect. And then you said reviews. You said, was it 3 weeks and 3 months? Or
no,
is it vary on cases?
Yeah, that's sort of case dependent. I would normally bring back most extraction cases after 3 weeks, just to check that everything's healing okay, the patient's happy, you're happy, and really to remove any sutures that haven't fallen out naturally. Yeah. And then it will be on to the more longer, soften and hard tissue bony remodeling, and we know that actually that takes a full 6 months. Yeah. But 3 months is actually the point where we could think about re-entering or removing and doing something else, whether it be another definitive bridge or an implant. Yeah. So, and at the review appointment, you'll be checking the occlusion, ensuring the posterior teeth are coming to contact, and you'd be looking at to remove the bite stops that you placed. If they haven't, they're naturally going to wear down because it's glass ionomer. But there'll always be something left that you will need to remove and make sure that the molars are coming to contact.
But I mean, you've mentioned communication a lot, lab communication mostly, little bits of patient communication in between. Are there any specific things you think really important patient communication wise? Obviously, you said if you're going to be opening the bite somewhere, or
yeah. So I tell all my patients again,
it's for smiling with, not for.
Yeah, it's exactly the same with composite work. If you're doing a tooth wear case in composite, any time where you're raising the OVD or interfering with the occlusion, the patient has to be aware of that, and they've got to be consented properly. So I would always say that speech can be potentially affected. With a single tooth, it's rare. With multiple teeth, it's increased chance of affecting their speech. So I always say speech can be affected. They're going to have to chew their food and take more time chewing on the back teeth and cut the food up into much smaller pieces. That helps them adapt to the occlusal changes that you've done for the patient. Always obviously warn them of risk of debond, but these things actually planned properly have got a pretty high success rate in the anterior zone. And I mean, really, actually, that's actually really it. And you just reassure them and tell them you're going to monitor the occlusion, and we'll be replacing this at a time when everything's healed.
Perfect. I mean, that you've covered it all through. Lovely. Have you got any other sort of cases you want to flow through, or now that we sort of could bring it together, or?
Yeah. Sort of so I think that I'll show you one of the cases.
And guys watching, if you've got any questions during this time, just sort of pop in and we'll get them answered. Let's crack on.
So this was actually this case on the left here. This was actually the case earlier that I showed with the PMMA acrylic bridge. Yeah. So I removed 2 old crowns on that side, and I prepared the other tooth for a crown, the canine. And these are the 2 teeth that are being removed. The upper left one, upper left 2. And this is on the day of removing those teeth and then relining this temporary bridge and then cementing it with temp bond. So that's what you should expect it to look like at the time of fitting.
And by relining, you mean internally fit surface rather
yes,
than
yeah.
Pontics
Because
or anything like that?
because obviously the lab have
Guesstimated.
they've guesstimated the preps. They don't know what's underneath. So you've then got to prep the teeth as per the model, as close as possible, and then reline that with acrylic or some form of composite or bisacral material.
And so your Luxatemp or whatever. And
yeah, but ideally with acrylic, you want to reline it with acrylic.
Yeah.
And then that can be cemented with temp bond, and then we can see I've sutured around the sockets here. Now, in a case like this where there's perio, we know that these gingival margins are going to shrink back quite a lot. So well, I've preempted that, but I remember I showed you the socket extension of the ovate pontic.
Yeah.
So that was then obviously going into the socket, and that's going to support it quite a lot. Now, when it comes to actually modifying these bridges, what you should do is when you remove it, air braid the pontic, and then you go through just bonding protocol with Scotch bond or your Prime bond, and then you add composite, light cure it, and then you polish it with your Softlex disc to make it nice and smooth so soft tissue adapts to it nicely. So that's how it's a very easy way of modifying. And you'd modify it when after 3 months you've had recession or soft tissue changes and you want to keep the patient going longer, or you want to modify the soft tissues. That's when you take it off and remodel it and adapt it to the way you'd want it.
Yeah, that's what I was going to say. Is that, have you got situations where you are going in and maybe taking it off 2 or 3 times and change it like you would with sort of implant emergence? And
yeah,
you're sort of tweaking that and sculpting
yeah, definitely.
That
so you'll sculpt the gum and you'll put pressure in certain areas, you relieve it in certain areas, and by adding and removing composite and putting soft tissue pressure, that's how you get a lovely emergence from the soft tissue. So it looks like it's not a false tooth. It will look like a tooth actually coming out of the gum. So just spending time modifying that. And you know, this is the same patient with that PMMA acrylic bridge. This patient has been in the temporaries for maybe say 3 months, and this is what you want your soft tissue to look like. You know, you've actually got mini sockets there that your final bridge work is actually going to fit into, and that's how you get that lovely emergence profile. So that's what you should be looking to see when you remove your temporary bridge at 3 months, if you modify the soft tissues correctly. So the socket is completely healed around your ovate pontic, and that's the kind of shapes that you get.
So is this going to be your go-to, if you're thinking for this patient, definitive bridge is the way to go, is this going to be your go-to pretty much every time for temporary measures?
Yeah, for anterior work in the aesthetic zone, you have to go to temporaries for something like this. You know, you charge the patient appropriately. You charge them for the temps, you charge them for your time. And if you just say to them, look, this is the way that I want to work, or this is the way that I do work, and you will need to be in a set of temporaries prior to going to finals to account for modifying soft tissue, identifying any issues with the abutments, loss of vitality, sensitivity, speech, aesthetics, function.
Trial run essentially before we commit
always,
to the really fancy stuff.
Exactly. Always go to temporaries where you can. And then the final is so easy because you've modified the temporary how you want it. And then you take pictures of that, you take an impression of your temporaries in the patient's mouth, and you say to the lab, make me a copy of this, because the patient's happy with the incisal length, the patient's happy with the emergence, the patient's happy with the line angles, the patient's happy with the occlusion, blah, blah, blah. And then they will just make a carbon copy of that impression that you sent them of your temporaries. It just makes that final definitive restoration so much easier. So now a lot of cases I'm just going always to temporaries.
That makes sense.
Another this is an interesting case and an annoying case, and it just shows you things that you need to look out for and where I've made mistakes. So again, this is just general practice. Patient comes in, and she actually came in with this upper right one crown in her hand on the emergency appointment. And she said, what am I going to do? I'm going to lose my front tooth. I've had this for 30 years. And, you know, I don't want a denture. So what I didn't notice at that time, but what I should have noticed, is actually how inflamed the gum tissue is around this post-crown. And the patient has got a really thin biotype.
Yeah.
So what do we think is going to happen when I remove that tooth? It's inflamed with a thin biotype. She's going to get quite a lot of recession. And that's something that I should have realized at the beginning. And, you know, it goes against everything that I've just told you in this presentation. But again, we're in general practice. Sometimes we've got a rush. We've got 2 patients waiting in the waiting room. You're trying to figure out what you can do with a patient's front tooth. And this is something that we'll present to you on a daily or weekly basis, lost front crown.
On a Friday afternoon.
On a Friday afternoon, yeah. So in this situation, what I did is I kept the post crown on the side. I would have taken an impression or a digital scan, and I would have explained to the patient, we're going to make you an immediate bridge. I'm going to cement it to the upper left one. So I prescribed exactly how I went through my presentation, and I then just provisionally re-cemented the post crown back in for the patient and just told her, obviously, this is a poor prognosis tooth. Let's just try and keep this going until I physically got that temporary bridge in my hand, and then I'll remove the tooth and fit the temporary bridge for you. So I did a digital scan here, and you can see again I've got my 3 holes, perforations. The minimum you want is 3, and I've got the location tag as well on the incisal edge, so that's going to be removed on the day of fit. So what happens is I take the tooth out, again being really careful, but I know that the gingival biotype is thin and the tissues were actually inflamed before I removed the tooth. So this is the rochette, the fit surface we can see has been sandblasted, and my composite tooth has got soft tissue extension that's going to help support those soft tissues to try and reduce as much collapse of that as possible. And this is how the patient ended up on the day of fit. So we've got pretty decent aesthetics. I've done my collagen sponge in the socket. I would have cleaned the socket out and got all the degranulation tissue, then put the collagen sponge. Then I've got my Vital Repeat suture, single horizontal mattress, and I fitted the bridge, and it looks pretty decent. And I would have then cut off this. Yeah, don't leave them with that.
Yeah.
I then would have cut off this metal location tag with a diamond burr, and then again just polish it with yellow band diamonds and softflex discs. And that's the platal aspect on the day of extraction. I've cemented that with glass ionomer, and we can see how the cement comes through the perforations to create a mechanical lock. This patient, because there's no prep, and I think the occlusion was quite tight, there wasn't any space, I decided to put GIC stops on the molars to help with longevity of this bridge. And this is what she ended up like at 3-month review. So we can see that although my ovate pontic is still supporting the soft tissues, we've now ended up with quite considerable soft tissue loss. And what I should have done now, reflecting on this case, when I saw her here, what I should have done is actually removed as much inflammation as possible before I extracted the tooth. And that would have been scaling, cleaning around that root, essentially doing perio on the tooth before you actually extract it. I could have used some of my steroid ointment or whatever, but I needed to try and reduce some of that inflammation because of the thin biotype. It's just going to disappear the soft tissue. And without managing that inflammation at the beginning, before I actually removed the tooth, this is actually what you end up with. in 3 months' time, which doesn't look very pretty.
Mm-hmm.
So, I mean, the plan for her was to always go for an implant. So I did soft tissue grafting and bone grafting, and we got a pretty decent result. But if you're not going to go for an implant, how do you then get yourself out of this situation? And even with an implant, this is challenging, and my implant still doesn't look 100% perfect. It looks better than what it is on the screen at the moment. But these are all the little tiny things that I've learned, that by spending time planning before you remove that tooth, doing cleaning around the teeth prior, reducing inflammation, studying the biotype, supporting the soft tissue with the Pontic, all these little tips and hints will help you try to avoid situations like you see in front of the screen right now. So hopefully that hasn't just been me rambling on, and we've given out some tips that people can take back tomorrow to practice.
I think so, man. It's a really great overview. I'm grateful for the new 4-hour thing, because otherwise I'd have been stressing trying to cut you off. And that was fantastic. If anyone's got any questions for Amit, please pop them in. But not like really great overview. I think it's something that I personally don't overly consider, because I think as soon as it's starting to get towards that kind of thing, like implant in our practice, it is you go to Nick for a consultation, and he then does that, and maybe it comes back, say I did that one where I extracted, sort of decoronated, left some root, made an ovate Pontic and bonded it either side kind of thing. So maybe I'll get it prescribed back to me, but I don't maybe look at it from my own point of view of doing it. I just end up doing it when it's been prescribed.
Yeah, I think with this, again, with the patient, if it's a patient you've been seeing for quite a while, they want you to do it for them. They don't want you to refer them to someone else, even if it's in the same practice. They want you to do the treatment because you've been seeing them for 2, 3, 4, 7, 8 years, and again, less things that you refer. If you can provide a treatment like this for the patient without just simply going for the usual immediate denture, then again, you can improve the patient's quality of life. You can give them a really good aesthetic outcome. It's less intrusive, and it will prepare them for the next step. And it's looking at all these final details where you're managing the soft tissue that will make your final restoration look so much nicer. We want to be able to, I'm sure people don't go into dentistry just to do exactly the same thing every single day. So if you can, even if it doesn't mean you can provide an immediate bridge in the next month, just starting with these little hints and tips with the extraction process. I probably do an extraction a day. I'm a GDP. So, again, if I'm taking a tooth out, I'll make sure that I'm following that set process. A tooth does not get removed without cleaning the socket. A tooth does not get removed without suturing it. And although some people may see it as a faff, what I feel is a faff is the patient coming back in a week's time with a dry socket. And I'd rather spend 5-10 minutes cleaning it and stitching it rather than them wasting time in my diary in a week's time, moaning in the fact they're in pain. Touch wood, I don't want to jinx it now, but that literally just doesn't happen.
Your diary tomorrow, now that you've said that,
I'm going to have 5 dry sockets.
That's true of everything. It is, I always said it with the impressions and things like that. It's, taking the time to put a bit of putty in your primary instead of slapping alginate in. It's going to save you a review later down the line or whatever. It is better spend that 5 minutes to save that 15-minute appointment or half an hour appointment or whatever it is. I think you've stunned everyone to silence and blown them away. So right. I'll finish up with the last little question I've been asking people now is the sort of the newer dentists and things like that, which includes me really. But have you got any particular tips, things you wish you knew before or wish you did earlier, cleaning out sockets, or any particular courses that you recommend? Just top tips for the young guys like me.
Yeah. I know this sounds really strange, but honestly, communication. It's such an important part of our job, but people don't realise. Everyone focuses on doing the clinical aspect and doing a lovely posterior composite with fissure staining, or doing an onlay prep that you can post on Instagram. But actually, if you just spend time talking to your patients, that will make you such a good dentist, because you understand their pain diagnosis, you're listening to them, you understand what they want so you can meet their expectations. The biggest problem in our profession is if we can't meet the patient expectations, that's when we get complaints. So I spend a lot of time trying to find out exactly what the patient wants. And that's why, bringing back to this lecture, they will go in temporaries majority of the time, because I would rather adjust my temporaries and add composite to them, polish them, change the occlusion, change the speech, blah, 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 in temporaries, rather than get that headache in the finals. So for young dentists, don't rush to go straight to the final restoration. Do your workup, speak to your technician, and get them in decent set of temporaries if you're starting to do cases like this, and use that as your trial smile before you go to the finals. And that, again, is all part of the consent process and patient communication. Because if you can physically say to the patient, I've made your temporaries like the final, like I made your finals like the temporaries, then they're going to be happy because they've been happy in the temporaries. What you don't want is to shock the patient with the finals, and then that's not what they're expecting. Because what they see in their head is Angelina Jolie smile, right? And what we see in our head is what can we physically achieve, what's possible, given the situation with the perio, the biotype, the occlusion, tooth wear, bruxism, all the clinical factors that play a part in how we do these treatment plans. It all stems from actually communicating with the patient, managing the expectations. So number one tip for young dentists is undersell, overachieve. And the second thing is clinical photography. If you looked at my laptop, I've probably got about 6,000 images. I've been a dentist now for about 7.5 years, and I was taking pictures in VT or FD. And now I've got a bank of most clinical situations, or I've got something to show a patient that, okay, I've done one like this. This is what it will look like, or this is what we're aiming towards. Is this something that you're thinking of having as well? So that helps with, again, doing the kind of treatment that we want, proposing treatment and getting treatment acceptance, but also documentation, and you improve your skill. So photographs, I would rather that a young dentist went on a photography course rather than they went on an Invisalign course, or rather than they went on a toothwear course. If you get good at photography and documentation, and storing your photos properly, then that will make you a much better dentist than a lot of the courses out there.
Makes you enjoy it more as well.
Photography is enjoyable, yeah. It's, again, a lot of people say, why are you taking so much pictures? But you'll pick up things on there that you didn't see in the patient's mouth. You'll go home, you look at the picture, and you'll be writing the treatment plans to the patient, and you'll see the crack on the upper left 6 on the picture that you didn't see in the patient's mouth. And then now suddenly you've got to tell the patient or quote them for an onlay or a crown. So again, I'd rather I do that and have the full set of pictures rather than get to finishing the treatment and then the buccal cusp on the upper left 6 fractures off. And I actually should have just looked at my pictures and realised it was there in the first place. So again, communication and photography is what is going to make you a better dentist. Try and stay away from certain courses and the glitz and the glamour. Go on courses that, like occlusion courses, stuff that is the bread and butter of our daily dentistry.
So are you for every clinical course, do a soft skill course? You sort of try and follow that kind of thing, or you say do a communication course, do a photography course, like not just do, as you say, clinical, because I know some people
Yeah.
say that, do for every one
Yeah.
of those, go and do even if it's a
Yeah.
finance or a.
I mean, we're meeting different people every single day. That's our job, talking to patients. So, and again, because someone like myself, I guess I've done quite a lot of studying, you end up being so clinically focused, but actually you need to take a step back and realize, what does a patient actually want? Because I actually did a consultation before I came to do this live, and I'm looking at the case thinking, I can do this, I can do that, we'll do this. But actually, I just said to the patient, what do you actually want? And she says, do you know what, Amit? I've listened to everything you said, but I just want this one tooth fixing. That's the actual one that bothers me. I can afford financially to have all the treatment you proposed. I can spend the time to come in the chair and have the treatment done. I'm not nervous, but actually I'm quite comfortable with my smile on my mouth. I just want this dark tooth fixed. So can you just do that? So again, communication is just key, and there's quite a few courses on that. There's so many communication courses. Just find one that's good. Ashley Latter. There's a guy called I don't know the name of the course, but there's a dentist called Asif, I think. And there's lots of different communication courses that you can do just to help manage patient expectations. And then photography courses, again, there's loads. Mike Sharland does them. Amit Patel does them. If you do some sort of 1 year restorative course, they'll always have a photography element. But again, just practice. Yeah. I've done the courses like Mike's and Minish's. And all respect to them, they're great courses, but they can't physically come to your practice and help you take photos. You need to do it on your patients. So I will spend time just taking pictures of just as of many things, if it's an amalgam fitting, a composite, a crown, denture, you just keep taking photography, and you'll find that your actual photography is getting better, and your clinical execution will get better as a result of the photography. And then when you come to store the photos, just be organized. So have folders, have the patient's name, and then in that folder you have pre-op, wax up, provisionals, lab work, and then finals. And then
you got to do it when you start, because it's a nightmare to go back and try and start and do it.
Exactly. I mean, I know you applied for aesthetic dentistry awards, didn't you?
I did. So did you.
So again, with awards, and again, it's not for everyone.
Yeah.
But if you're going to apply for something like that, you need to have the kind of photographs that me and Rupert are taking, and having the pre-op, the diagnostic work, the lab work, and the finals. They all need to be neatly organised, because if you just send in a case with pre-op, a prep, and a fit, that's not good enough for that sort of level they're looking for. So again, not only does it help you with applying for awards and stuff like that, if that's your gig, but also it massively helps with documentation. And again, I will always, every time I remove a crown, whether it be an £800 case or an £8,000 case, every time I remove a crown or a restoration, I'm taking a picture of the tooth, what's underneath, because I'm showing the patient, this is what was underneath your crown. There was gross decay, there was a crack, the root filling is not good, it's leaking. So then again, it's documentation. If the patient ever comes back and says, my tooth has got an infection now, blah, 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 I said, well, actually it's because this was what I found when I removed your crown. It's a great tool to educate patients taking photographs. And again, if you want to do more high-end treatments or cosmetic treatments or restorative, by taking photos, you'll be able to show the patient, these are works I've done before. and you can also document them for your postgrad training or whatever.
Well, that's with mine now is obviously, you know, I do general dentistry, but I do obviously a lot of what you see on here. But this almost now acts as a catalogue for patients. I'm like, do you want this, or we can do something like this or
it
this?
does.
It's useful like that. Peter's asked recommended occlusion courses. So where's your knowledge come from? Is it the MPin? Is there various things?
Yeah, I mean, there's lots of one-day courses. The British Society of Occlusal Studies. You can go on their website, and they will have what sort of one-day courses. You can do occlusion as part of a much bigger program, which is like what I did, Implant Dent, but also any crown or bridge course that you go on, like Attic Rahman, I did his course, or Mahul Patel crown course and veneer course. You'll always get little gems regarding occlusion. But because I did King's Implant Dent, I was trained with the Dawson Principles of Occlusion.
Right.
So again, you can look at Coyce or Dawson. You could go to America and really, really learn the ins and outs of occlusion. I haven't done that yet, but that might be something that I'll be looking into. I think with that will help you, sort of guide you in terms of occlusion, because again, that is something that we're managing on a daily basis. If you do a composite filling, if you do a denture, a bridge, you have to be able to assess and manage the patient's occlusion. It is what we do every day. So you need to understand it. It's important. And actually broken down, it's actually quite simple. You just need someone to explain it in a simple way that we can understand. And that's what I learned at King's. They just taught me in a simple few key points what you should be assessing and what occlusal principles you should follow when you're restoring a patient. And so far, again, I guess I'm still newly qualified. I respect my colleagues that have been in practice longer. I've got a lot to learn, but so far it is working what I've learned. So hopefully that'll help the person that asked the question.
Perfect. And then we got one last one coming up. What camera are you recommending for beginners? So what do you use? Canon, Nikon?
I've got a DS, so SLR. I've got a full Canon setup. It slightly bugs me when people say the camera setup's expensive. And the reason why it bugs me is because you've got to see it as an investment. Yeah. My £1,500 camera setup has probably made me about 150,000 in cash. So you can't look at it as the initial £1,500 outlay. You got to look at what kind of dentist is going to make you, and the investment in yourself and the money that will bring in order to pay for that camera, because it will just take your dentistry to a whole new level, and you'll be able to do the kind of dentistry that you want to do. So I use a full Canon setup. So that's a Canon body. I think it's an 860D or something like that. And it's a Canon lens. I use a 60mm macro. And the reason why I use 60mm macro compared to a 100mm macro is because it's lighter. I find the 100mm lens for clinical photography too heavy. And I know a lot of dentists use it, but the 60mm means I can actually get close to the patient rather than being so far away. My arm's not extended so far, and I basically don't shape so much. So my pictures are actually in focus when I'm using a 60mm macro lens. So I've got 100 as well, but I just prefer the 60. And I'm using a twin flash setup, again, Canon flash with an owl bracket. So that's, maybe the total cost of that is about £1,500. If you didn't want the owl bracket and you wanted to stick with a ring flash and not twin, it'll probably be about £1,000. You'd say about £500 on that setup.
Yeah, and as I say, it's the investment side, the communication. I mean, even was it today or yesterday? It was, new patient, both upper sixes, DO amalgams, mesial crack line, buccal crack line, quick mirror, bang, photo, put it on the screen on the thing, 2 onlays, yeah, great, £1,000. Yeah, it's like it's paid for itself. It's done.
It's paid for itself, exactly. And again, it's not all about money. It's actually the patient education, because when we say to a patient, "You've got a crack in your tooth," they don't understand what that means. Like, what does that mean, a crack? But if you show them a high definition crack on a tooth blown up, they will understand the consequences of not treating that. We know the consequences of not treating it are eventually tooth loss. So if you said to a patient or shown a picture, "Here's a picture of the crack," if it's left untreated, then there's a high chance of tooth loss, then they're most likely going to do something about it. So it's education. This is not trying to sell something to the patient. This is just educating them in a way that they will understand what you're trying to propose. It's no different to drawing a diagram and explaining a procedure. We can't assume that patients are on the same level that we're thinking, because they're not. If you went to their job and they tried to tell you about the finance and whatever, I wouldn't have a clue. I'll just be sitting there thinking, I've got no idea how the stock exchange works. I would need them to explain it to me in layman's terms, or show me on a computer exactly what their job entails. And it's the same for us. We need to educate the patient and explain to them. And because it's in the mouth and they can't see it, the only way of doing that is...
Yeah, no, absolutely. It's the patient communication, education. It makes your life easier as well, as you say. There's less sort of resistance on it and things. And they said, "Thank you very much. Makes so much sense." One last one, another one about courses. We need just like your CV, like. They want any recommendation in terms of implant courses, but I don't know if they mean placement or restoring. How did you start? Were you just restoring?
So I
know the MClin is focused on restoring, really, isn't it?
Yeah, I think if you wanted to get into implant dentistry, if you're not placing yet, start off with restoring. So find a practice that you can team up with, or your implant surgeon in your current practice, or if there is no one providing implant dentistry, then just start by restoring first. Again, learn the principles of soft tissue management, aesthetics, occlusion, and just get good at restoring, learning the components, because it's easier to restore and then get into surgical placement. So, because implant dentistry, it is a restorative process. The periodontist will disagree with me with that. But I believe it's a restorative process. So you envisage the final restorative result, basically what you want the tooth to look like, and then you work back from that, and that's where you place the implant to accommodate for where you want your final restoration to be. So that's, I'd always suggest restoring first. So I did a great course with Straumann. That was a 1-year course. It was the ITI, who are one of the biggest basically implant societies in the world. So ITI, in partnership with Straumann, I did the 1-year implant diploma with them. Yeah, and then I did the Royal College of Surgeons implant diploma in London. That was 2 years. That was a fantastic course because it gave you a lot of structure, and it really got me confident in placing dental implants. I've done a few 1-day courses, 2-day courses, stuff like that. But I think the biggest one for me was the Royal College of Surgeons course, because the mentors on that program were fantastic. And they basically, the people that wrote that course and the examination process were the same people that wrote the GDC standards on implant dentistry. So if you want to do textbook implant dentistry, I believe that course is up there. And that's where I learned a lot.
Yeah, I mean, on the ITI side of it, I'm actually a young ambassador for the ITI, so I'll do my little bit now. Yeah, absolutely, the dip looks really good. I'm actually going to be doing a little bit of teaching on it soon, actually, the implant overdenture side. I'm going to start doing that, which is cool. But yeah, particularly as I said, if you haven't got an implant dentist in your practice and you want to, go, where do you find these people? But they have study clubs, local study clubs, so you can go, and it's usually sort of county sized or things like that. You know, I'm in the Reading one, or I presented to the Chelsea Southwest one, or whatever. So you can meet a lot of other dentists like that. I think great for finding mentors and maybe people to work with, collaborate with, or shadow or whatever. So if you're interested in implant dentistry, it's well worth it.
Yeah, 100%. Yeah, and then I think the last thing to add with the courses, I did a recent one called MAGDS, and that's a membership in Advanced General Dental Surgery, RCS Edinburgh.
Okay.
And that was a really good, it's an examination process.
Is it like MFDS Part 3?
Kind of, yeah. You can only do it if you're minimum 5 years qualified. And it sort of puts you in the tier 2. If you pass it, it puts you in sort of the tier 2 level of general practice, like just below a specialist level. It was a tough exam, but it just makes you a better dentist. It really, really sorts out the the men from the boys or the women from the girls. It just really, really makes you think about dentistry as a whole and holistic approach. Looking at general medicine as well. So it's not just all about clinical dentistry. It's about managing the patient.
Your co-workers, John.
Yeah. So so she did it as well. Lainey did that, and it is just a really, really good examination process. And I would recommend people to do that if you're 5 years qualified.
Perfect. Well, I think we must have answered everyone's questions by now, but I think we'll have cut it there, man. Cheers for that. That was fantastic, and hope, as I say, people took a few little bits and bobs away. That rounds off a really good month in July. We've got lots of cool people coming on August. Next up is Alan Bergin, Cornish dentist. He's running through his course that's coming up soon, which will be cool. But yeah, cheers, dude, and I'll see you at the Aesthetic Dentistry Awards, right?
Yeah, thanks for having me on. And any questions that people have, just drop me a DM. That's no problem. And I'll see you at hopefully I should be going. I've got a baby now, so I have to see.
Oh, come on, man. You got to go for that.
Yeah. All right, mate. Thanks a lot.
Cheers, people.
All right. See you later. Bye.